Hello guys, welcome to Whiteboard Doc. In this lecture, we'll be learning about focal segmental glomerulosclerosis, that is FSGS. Now this spectrum is part of nephrotic syndrome. Let's go over this. What does focal mean? Focal means that only some glomeruli are involved. Only some glomeruli are involved. And what does segmental mean? That only some part of the affected glomeruli are involved. Only some part of affected glomeruli are involved. What does this mean? Suppose I have some 100 glomerulus with us. Okay, this is 100 glomerulus of one kidney. Out of these 100 glomerulus, in FSGS, only around 50 glomerulus will be involved. I'm just taking an example. And those 50 glomerulus that are involved, only about some parts of these glomerulus. Let me change the color. Only some parts of these glomerulus, of the affected ones, they are involved. So this is the meaning of focal segmental glomerulosclerosis. That only some glomerulus of all the glomerulus are involved and only some part of the affected glomerulus are involved. So this is the basic meaning of focal segmental glomerulosclerosis. Moving on to the causes, most common cause is primary, and this primary cause is due to idiopathic cause, that is idiopathic FSGS. We actually don't know why FSGS is occurring. So this is the most common, that is primary. It can also occur in association with infections such as patients suffering from HIV, patients who are on IV drug abuse such as heroin, also patients suffering from sickle cell disease, as well as a consequence of late onset obesity as well. So it can occur in association with HIV, heroin abuse, sickle cell disease, as well as obesity. It can also occur on the background of a secondary event such as IgA nephropathy. We have a separate lecture on IgA nephropathy. Kindly watch that. As we have said that in the other lecture as well, in IgA nephropathy, that patients suffering from IgA nephropathy will eventually move on to FSGS in their lifetime. Moving on to the FSGS can be a adaptive response. It could be adaptive response seen in such as renal ablation, then unilateral renal agenesis. It can also be due to renal dysplasia. So these are the three conditions. These three are congenital conditions. So FSGS can occur due to adaptive response seen in renal ablation, unilateral renal agenesis, as well as renal dysplasia. So these three are part of congenital. It can also occur in conditions such as reflux nephropathy, as well as hypertensive nephropathy. Reflux nephropathy and hypertensive nephropathy. And these two are acquired conditions, they are not congenital. So FSGS can occur as an adaptive response, which are seen in renal ablation, unilateral renal agenesis, as well as renal dysplasia, and these three are congenital conditions. Then we have reflex nephropathy as well as hypertension nephropathy, and these two are acquired conditions. This can also occur in the background of a genetic mutation such as involvement of the TRPC6 gene. We will discuss it separately. So these are the most common causes of FSGS. This FSGS clinical features will be similar to the nephrotic syndrome that we have, and this FSGS has higher incidence of hematuria compared to all other classes of nephrotic syndrome. This often results in reduced GFR as well as the patient can also have hypertension. So we can see we have two features of nephrotic syndrome: hypertension as well as hematuria. These patients can also have non-selective proteinuria. Non-selective proteinuria. These patients will have poor response to steroids. Poor response to steroids. And the progression to chronic kidney disease is 50% in 10 years. So patients suffering from FSGS, progression towards chronic kidney disease is up to 50% of them will progress towards end stage renal disease in 10 years. So this is the ultimate outcome of patients suffering from FSGS. How is this FSGS and what are the genes involved? We'll see. So if FSGS, number one, NPHS gene could be involved. NPHS 1 gene, and this is present on chromosome 19q. The protein involved is the nephrin. So nephrin protein is involved, and this results in congenital nephrotic syndrome Finnish type. We have congenital nephrotic syndrome Finnish type. Okay. So if the NPHS1 gene present on the chromosome 19q is involved, then the protein nephrin will be involved, and this results in congenital nephrotic syndrome Finnish type 1. Then if NPHS2 is involved, NPHS2 gene which is present on chromosome 1q, and the protein associated is the podocin. Protein associated in this condition is the podocin, and this results in autosomal recessive FSGS. Autosomal recessive FSGS. If the protein alpha actin 4 is involved, protein alpha actinin 4 is involved, this results in autosomal dominant type of FSGS. Autosomal dominant type of FSGS. Then as I just discussed, two more genes, they are TRPC6. Then we also have another gene called as APOL1 gene. If TRPC6 gene is involved, this results in adult onset FSGS. Then if APOL1 gene is involved, this results in African descent type of FSGS. African descent EFSGS. So this is the basic classification of FSGS based on the gene involved. If NPHS1 gene is involved present on the chromosome 19q, protein nephrin will be involved, leading to congenital nephrotic syndrome Finnish type. If NPHS2 gene is involved present on the chromosome 1q, protein podocin will be involved, resulting into autosomal recessive FSGS. If protein alpha actinin 4 is involved, this results into autosomal dominant FSGS. If TRPC6 gene is involved, it results in adult onset FSGS. And if APOL1 gene is involved, this results in African descent FSGS. Now moving on to morphology that we see in FSGS. So morphology of the kidney. What we see are focal and segmental lesions. So the name itself will tell focal segmental glomerulosclerosis. So what we see are focal and segmental lesions, and these lesions are seen in minority of glomeruli. These lesions are seen in only minority of glomeruli. What we see in the capillary wall, we will see hyalinosis. We can see hyalinosis of the capillary walls. We can also see diffuse effacement of the foot processes. Diffuse effacement of the foot processes. Then We can also see collapsing glomerulopathy. So these are the classic points that you need to remember as well as write in your exams for a better marks if FSGS has come to the exam. What we see in morphology of FSGS is focal and segmental lesions involving only the minority of glomeruli. We can see hyalinosis of the capillary walls as well as diffuse effacement of the food processes. Why we can see diffuse effacement of the food processes? We have just discussed here, protein porosine will be involved. That's why. Then we can see collapsing glomerulopathy. The clinical features, as we have just discussed, it will be same like the same nephrotic syndrome features. Same nephrotic syndrome features. Okay. And this patient suffering from FSGS will have poor response to steroids. And there is very little tendency for spontaneous remission in patients suffering with FSGS. So patients will have very little tendency for spontaneous remission. Spontaneous remission when it comes to FSGS. Around 20% of the patients suffering from FSGS will ultimately go into renal failure. In 2 years. Sorry, this is a glitch in my iPad. I don't know why this came. Then patients suffering from FSGS will also can have recurrence up to 25 to 50%, even if we did allograft transplant as well. So patients can have 25 to 50% recurrence if the patient has undergone allograft transplant. So this is the basic lecture that you need to know about the FSGS, that is focal segmental glomerulosclerosis. If you found this lecture helpful, make sure that you like, share and subscribe, and also share this lecture to other medico friends that you are watching. Thank you guys. Thank you for watching.